Besides there were unit two. Yeah. No, there, it was like this. Or. Yeah. Yeah, right. It was something like yeah. It's not just two, but so at least now. Yes. No, that's what's wrong. There. I can't wait, but this kind of for last week, yeah. We'll find somebody. And just a month and a half, it's not great. Yeah. Yeah, I'm he doesn't know my situation. Was felt like this is kind of swing over. Right here. Right here.
I don't know when it comes back.
I put it on my, I have like a calendar on my iPad and Word, and so.
Where's the administration on this side now? All right, I like it.
Yeah.
All right.
Thanks.
I'm gonna stay far over here.
No, yeah. Not that it's.
Yeah, that's fine. That's so hard.
I thought I was gonna say something about being that big. Outside, yeah.
Did you have 9 people? You got the Sarah and.
Good afternoon. We do have a quorum, and I know there's a few more people coming, but since we have a quorum, we're gonna go ahead and start. So I'm gonna call the meeting to order, and I'll start the interpreter to please give his instructions.
Speaking. My name is Ricardo Garcia. I'm one of the Spanish interpreters, along with Gladys Ramos. To access the interpreter via Zoom, via computer, after the host activates language interpretation mode, click the language that you would like to hear. English and Spanish interpretation is available. Optional. To only hear the interpreted language, click the original audio. Via phone, in your meeting control, tap more at the bottom right in the mobile phone app and top right in the tablet app after the host activates the language interpretation mode. If the icon is not visible, tap the screen to make it appear. Reminder, speak slowly, pause between sentences, speak clearly, avoid interrupting or multiple people speaking, avoid using metaphors, acronyms, slang, or idioms. Interpret signals during the meeting, speak slower, raise your voice, interrupt for clarification, or communicate a concern. Acceso al intérprete vía Zoom por computadora. Después que el anfitrión active el modo de interpretación del lenguaje, haga clic en el lenguaje que desea escuchar. Interpretación en inglés y español estarán disponibles. Opcional. Para solo escuchar el lenguaje interpretado, haga clic en silenciar audio original. por teléfono. En los controles de la Junta, oprima More en la parte baja de la derecha de su aplicación del teléfono y en la parte alta de la derecha de su tableta, después de que el anfitrión active el modo de interpretación del lenguaje. Si el símbolo no está visible, toque la pantalla para que aparezca. Recordatorio: hable despacio, pausa entre oraciones, hable despacio, evite interrumpir o hablar varias personas entre sí, evite usar metáforas, siglas, doble sentido o modismo. Señales del intérprete durante la junta: hablar despacio, levantar la voz, interrumpir para clarificación o comunicar un asunto. Thank you so much. Muchas gracias.
Thank you. Okay, moving along, we're gonna have a roll call that we do by introductions, so I'm gonna start with Soledad, if that's okay with you. And is that okay with you? Okay, so your name and the district that you represent, and if you're an officer, please also state that. And we do have one new member, but when she gets here, we'll get to her, we'll introduce. Okay, thank you.
Okay, my name is Soledad Barragán y represento el Distrito 5.
District 3.
Good afternoon, Michael Rodriguez, District 5.
Hi, Donia Robkin, District 4.
Hi, Sean Pusey, law enforcement representative.
Hi, everyone, Matt Levere representing the Board of Supervisors.
Jeff Davis, District 2.
I'm Sylvia Garcia.
Oh, sorry to press the red button.
Sylvia Garcia, District 3.
Then I'm gonna just interrupt you for a minute. Sylvia, would it be okay with you just to introduce yourself just a bit, just because you're our newest member? We're happy to have you in just a couple sentences.
Okay, yes, my name is Sylvia Garcia. I represent District 3. I have a family member that is part of behavioral health. I'm also a consumer. I'm a veteran, 10 years of service. I live in Camarillo and I'm really happy to be here. So thank you.
Well, thank you and welcome. We're happy to have you. Sorry, Andre.
Andre Walker, representing District 1.
Good afternoon, Maria Torres, representing District 5. Janice Gardner, appointed by District 3, but now living in Supervisor Corral's district.
Diane McKay, District 2, and I am the first vice chair.
Cheryl Heitman, I chair the board on District 1.
Good afternoon, everyone. Loretta Jenner, behavioral health director.
Good afternoon, Martha Knudsen, on behalf of the county council's office.
DJ,
Yes, CJ Key, District 2, and secretary.
we got everybody. Thank you all for being here. That's great. So approval of the agenda is our next item. That is, takes a roll call and a motion first.
I'll make a motion to approve today's agenda as written.
Second.
Been moved and seconded. Is there any comments, any changes anybody wants? Okay, if not, we have a roll call. I'm sorry, CJ, are you ready or do you want? Okay, great.
All right, so then Africa,
Yes, I'm here.
Andre Barbara,
Beirut.
and Nancy Wilkins. Jeffrey Davis.
Yours.
Say yes, say yes.
Yes. Sorry.
Okay,
Sorry.
Genevieve. Morris.
Alright.
There's a lot of traffic. Sylvia Garcia,
Yes.
Janice Gardner,
Yes.
Matt Levere,
Yes.
no.
Yes.
Diane McKay,
Yes.
Jennifer Morrison. John Person,
Abstain.
Daria Robin,
Yeah.
Michael Rodriguez,
Yes.
Marlene Torres,
Yes.
and Chair Piper.
Yes, that motion passes. Thank you. And now we move on to the minutes, the February 24th minutes, and remember, you can vote on this, even if you weren't here, if you have read the minutes. Is there a motion to approve?
I'm over to the minutes.
Second?
Second.
Thank you. Okay, CJ, sorry. Again.
All right. So that Barton,
Yes.
Andre Roban,
Yes.
Nancy Borchard, Jennifer Davis,
Yes.
Sylvia Garcia.
I did not read the minutes.
You can abstain.
Abstain.
Like Janice Gardner,
Yes.
Matt Rivera,
Yes.
Bill Lees,
Yes.
Diane Kay,
Yes.
Jennifer Marcy, John Percy,
I made a mistake, so for the, please change my vote to yes for that, and then for the minutes abstain, please. Thank you.
I thought that was
okay. Dalia.
Yes.
Michael Rodriguez,
Yes.
Marlene Torres,
Yes.
and Chair Piper.
Yes. That motion passes. Thank you. Moving on to public comments. We have one that was mailed in. Emailed in, and there's a copy at your desk at your place. Everybody should have a copy of that, and will also be included in the minutes of next month. Any other public comments? I don't think I'm seeing any up there. Ah, perfect. Please come forward.
Good afternoon, my name is Scott Walker, from the Sheriff's Office, and previously at the CIT program, so your honoree is coming up here. I'm running a few minutes late. I just want to say a couple of things, if that's all right, because I know you have a full schedule, agenda next month, so. Today, the BHAB is going to recognize a remarkable CIT officer from Ventura Police Department, Corporal Elise Kuros. Elise has done it all with CIT. She's been a student, a scenario actress, a scenario evaluator, and instructor. She's been volunteering with CIT before she actually was even an officer of the Ventura Police Department. And I really have Ventura Police Department to thanks for loaning her out for so many times that we've been able to utilize her in the program. Also want to thank BCBH, NAMI, Tri-Counties Regional Center, and the Autism Society, because they've all contributed to be part of the great training that Elise has gotten through the CIT Academy. And I want to really thank the BHAB. Thank you for giving us the opportunity to recognize officers that are not part of the normal yearly cycle when we do that. I know you have many more CIT officers next month you're going to recognize, so I want to thank you for that. These partnerships are really vital to the program success and to the community safety and just respect for everyone that's out there. So I just, Elise is just a great example of that, going from actress one day to student to now mentor of other CIT officers out in the community. So thank you, everyone.
Well, thank you. And you said she's on her way?
Yes.
Okay, all right, well, she's next on the agenda, but we're gonna pass on that and move on. Thank you for that. Okay, so I'll move on to chair announcements. This month is a busy month. March is at the National Social Workers Recognition Month, and we have many social workers working in our department and doing a great job. And often they are not recognized as they should be, not because the department doesn't recognize them, but I don't think people in the community realize the depth of how much they really contribute. So we want to be sure we recognize them. It's also the Women's History Month, and we want to acknowledge that. And we have a Woman of the Year, as our Vice Chair Diane McKay was appointed as Vice Chair by the Assembly District 42, or Jackie, or Assembly Member Jackie Irwin last week, representing the women of our district, and she's so proud to have her here. So it is Women's History Week. Let's see. Oh, I also wanted to call your attention since I have a little extra time. At the back of, towards the back of your packet, you will find the notice from the California Association of Local Behavioral Health Boards and Commissions. And this, I thought, gave a great rundown of potential problems on cutbacks with Medi-Cal and, as we call it, Medi-Cal, Medicaid, that's going on nationally and how it could affect the state and people who live in California as well as other places, obviously, but trying to give us an idea of the things that may be impacted. And as you look through that, you're going to see that many of them are going to be things that we deal with directly. So please take a look at that, read it carefully, and then they're asking for us to take action to send this out to other organizations and other people that we know would be interested. To see if we can get them to also participate in calling local legislators and writing people, however else you want to do that, if you feel so strongly about it, which I assume most of us will. But it will have an impact, because we don't know for sure where it's all going, but it will have an impact, and we just need to be aware of that and do what we can at the local level. And again, our local members of Congress have told us that even though they might be voting the way we maybe hopefully would want them to vote, we need to still contact their offices because they do count the number of people who either email or call in or contact them in any way. And that's useful to them when they're testifying about these issues in Congress. So don't think just because we are fortunate enough to have someone who might be supportive of not making these cuts, we want to make sure that we're still contributing to that. So just take a look. It's well put together. This is again by our state, California Association of Local Behavioral Health Boards and Commissions.
That's great.
Yeah. Yes, any comments, Diane?
I've already passed it along to a few people. It is terrifying when you look at rural, particularly what could happen here, but in rural places in the state where hospitals may close. And so just access to healthcare in general and mental health is just really quite scary.
Any other comments on that? Okay.
Madam Chair, just really want to thank you for echoing these. I have been in DC last month. Medi-Cal covers over 250,000 of just our individuals through Gold Coast Health Farm. So really advocating for the maintenance of the program. Our CEO, Dr. Felix Nunez, just also wrote an opinion piece that was in the DC Star and then the Pacific Post Business Times as well. So thank you for raising such an important issue for us, and we continue to advocate as we work through this final resolution and then ultimately reconciliation in DC.
Thank you. It's good to have firsthand knowledge.
Would you, thank you, Marvin, would you bring it back as soon as we find out anything? Oh, yes, I'm happy to at any point if you'd like me to bring any of this to you.
Great. Oh, great. Okay. Great. Okay, oops, sorry. Elise is not here still, is that right? Scott? No, not yet. Still coming. Okay. Well, then we're gonna move on. Here we can do director's report. Okay.
Good afternoon, everyone. If you look in your packet, we have a pretty thorough report this month, covering all of our areas within the department. I want to call out a couple of developments in our, starting with our outpatient clinical operations. We talked about for the past year, the transition with DUI services going from county provided to contractors. And so that transition is continuing. And we have a new East County DUI provider in Moore Park. So that's very exciting. Moore Park's not an area where we typically had a lot of services. So we have a new provider there. And the information is located here in your report. So the transition from county to the provider is underway and should be completed by the middle of next month. We are also excited to announce that we have Aspiranet will be providing, this is separate from DUI, but services in Moore Park as well. Within the Reuben Castro Human Services Center, which is great because that's a good location where we have our county HSA and First Five and some HCA affiliated services there. So those will be kind of prevention and early intervention youth services there. So we're really looking forward to that. That's been in the works for a while. So I'm excited to get that off the ground. Within our forensics and justice and reentry division, just wanted to give a nice update on Care Court. We've completed our first 3 months of operation, and so far we have 7 clients in treatment, which is great considering our county's not huge and we didn't know exactly what to expect. And this is actually more than what we're seeing across the state, right? Marty can attest to that. So we have so far 1 client's been discharged and successfully transitioned to treatment in another county. All 8 petitions have been, have met the court and legal requirements standards and were given to BCBH for the assessment. So we have some others in the pipeline, and some more for review, but so far so good. So, you know, we really didn't know what to expect. So this is great that we're seeing some stuff happen. Below that, we have some, updates on Prop 36, since a lot of people have been asking questions again for people throughout the state, like, you know, what is this gonna look like? So our department has worked very closely with our legal partners, assessing the impact of the law. And so we're coming up with our own local strategies to see what's gonna happen here as far as how we're gonna do the treatment, whether it's gonna warrant enough clients to either do in-house or to have a contractor. We're still assessing that and we'll continue to evaluate until, given the uncertainty of the number of referrals, we'll pause and make some assessments. All right, they're here. Yay. All right. Yeah, no worries. And then the last update, which we talked about a little bit last month, is on the BH Connect waiver. So we're finally getting more information on the state. And I told you last month we had some deadlines as far as opting in or not. So we have decided to opt into the BH Connect incentive program, again, to help build out the robust managed care operations that will be required as part of our responsibilities as the behavioral health plan. Will also help us as we start to build out our evidence-based practices and evidence-based programs for our full service partnerships, so our FSPs. A reminder that all of this work has to happen anyway as part of Proposition 1 that goes live in July of 2026. But in doing this also under BH Connect, we have the opportunity for some incentive dollars and basically we kind of get a practice run. So we've done a lot of analysis basically to determine the easiest way to put it is if the juice is worth the squeeze, because it's a lot of work when we opt in to do something optional with the state. But we do feel like this will give us an opportunity to work to really get the kinks out as we refine our FSP enhancement programs as we move to really focusing outpatient services on the most critical, moderate to severe populations. With that, we've also gotten some clarification from the state on some of the portions of the waiver, including the IMD portion, which I know has been a lot of interest to BHAB in previous years and currently. And we did get some clarification that I'm sure folks are not gonna like. So the hope was that the IMD waiver would allow for us to be able to bill Medi-Cal for stays and residential treatment on the mental health side, just like we could do under the substance use side under DMCODS. We were not gonna get, it was unlikely to get a blanket waiver to where you had unlimited stays. But what had been negotiated was 60-day stays. So you could have stays at like an MHRC or something like that. And then, you know, the first 60 days could be paid with Medi-Cal. And then after that, you transition to another funding stream. And that is not what's actually happening. What's actually happening is if you have a stay that is 61 days or more, none of the stay can be claimed to Medi-Cal. So that pretty much leaves us back to square one. Where we're using alternate funding sources for long-term stays, like your MHRC or step-down residential. Our MHRCs typically are about a year to a year and a half stay. So we use other funding streams. So it's disappointing because that's kind of what a lot of folks were hoping with the BCHIP waiver that, you know, or the BCHIP program, you know, we could build 120 beds and get reimbursed and all that would be wonderful, but the reality is nothing over 6 days would be billable to Medi-Cal. So very disappointing, but the focus really is on short-term, 60-day or less. So the type of facilities that really this would be beneficial for are, you know, inpatient units, not ours because it's an acute system attached, so it's a different billing system. But other freestanding psych, acute, or like a PUF. So in theory, when our PUF is up and, you know, hopefully we get BHAB and when our PUF is up and running, that would be a type of facility stay. But unfortunately, like our MHRCs wouldn't qualify because those stays are usually longer than 60 days. So that is the update there. Any questions?
Yes.
It's not in your report, but I know that you've been keeping us abreast of what's happening at Vista Del Mar, and I actually heard from a nurse who's working there that they are starting to take more VCBH clients. Is that true?
They have not been approved beyond their initial two clients.
And Michael?
With respect to the funding that you talked about, the 60-day cap, can the department get the first 60 days paid for? And
No.
then, so it's
That
just,
was the hope, is that we
Okay.
could do the first 60 and then transfer over the second bid to another funding stream. The state came out last week and finalized that now.
okay. Thank you.
Anything else? Oh, spoke, okay,
Liz.
Liz.
Thank you. Director Dennering, could you just walk me through what the other funding streams are and how well funded are those funding streams?
That's an interesting question, and it would take the whole rest of the meeting. But there are multiple streams, including what we have now as MHSA, which will be transitioning to BHSA. Our 1991 and 2011 realignment, general fund, tobacco settlement tax. I mean, there's multiple funding sources. And, you know, right now, we're okay, but post Prop 1, when everything changes, you know, we're gonna be very taxed. As we've talked about this meeting, we anticipate a probably $40 million reduction in core services, which includes our crisis services, it includes our prevention, early intervention, you know, so a lot of the buckets that we're currently using to fund some of these stays, you know, are potentially in jeopardy due to Prop 1 shifts, so.
And so do you anticipate that when this that we'll be able to manage perhaps for the first year after implementation goes live July next year? And if so, are there contingents? I'm sure there are contingency plans underway, but are there any other funds that we set aside that can be put into a pot for this for an additional funding stream, or are we already tapped into everything that we have at our disposal?
Obviously, we're planning multiple contingencies and strategies for the entire system transformation, and are actively planning as far as projections for the next 3 fiscal years, and then assessing, you know, once we, for lack of a better term, run out of money in one bucket, post Prop 1, to see what, you know, contingencies we'll have. That's a few years out. Hopefully.
Okay. So everything that we're talking about right now is in the 3-year strategic plan.
Correct. And all of this is contingent on Medicaid funding staying the way it is. I have to throw that out as a caveat. That is
Right.
not for mention. So everything that we're planning now is contingent on what we have. And if that changes, then that's a whole different story.
Okay, great. The only other thing I just want to say to everyone in the room, Chair Heitman, is that those of us on Zoom cannot see the individuals that are speaking. The OWL camera is not tracking. We have a split screen and we see, I believe it's Genevieve on the bottom, and then there's a very narrow strip. It looks like the Last Supper on the top of the screen. So if there's any way to get one view of the room so we can see who's talking, that would be awesome. If we can't, I just wanted to bring that to your attention. Thank you.
Thank you, Liz. We are aware, and are in the queue with the county as far as upgrades for this building, so, in this room.
Okay, so, okay, well, Genevieve, hi, I think that's Soledad. You guys look great.
So now everybody knows where not to sit. Okay, any other questions for Dr. Jennering on her report? Okay, well, we have the entire Ventura Police Department with us now. Thank you very much, officers. We all feel safer. So we're gonna move back, on the agenda to our recognition. And I want to have Elise, please join me up here. You will, please. So I do want to thank the members of the department who are here. We have 2 assistant chiefs. This is really impressive. You must get a lot of. And the chief. And the chief. Ah, wow, did you just get, are you the acting chief or you are the chief?
The interim chief.
You're the interim chief, okay, because I thought, did I miss something? Because I'm. For those of you who don't know, we're waiting for an appointment of not you, a real chief, that you're not. Yeah, permanent, yes, permanent, thank you. Okay. So today we are honoring Corporal Elise Kios. She's right here with me. And I'm gonna read you why to begin with, and then we have a couple of people want to speak, I think, on her behalf, and I also have a note from the dispatch center, which a lot of this took place in, right? Yes, good, okay. Corporal Quiros is an officer with the Ventura City Police Department. She was working in the dispatch center on October 18th, 2024, when dispatch received a call from the National Suicide Hotline. A 17-year-old autistic male was suicidal and said he was in Ventura walking to a bridge to commit suicide. The phone number he gave was not capable of being pinned. So they couldn't get his location at that time. But Corporal Quiros called the number and was able to reach the young man. She spoke with him for 3 hours, establishing a relationship, and he eventually shared his current location, which was actually our favorite bridge, the bridge at 23-118 interchange in Monarch, which we talk a lot about in this board. She was then able to give the CHP and VCSO his location, and they were able to reach him and get him safely off the bridge and into the hospital for further evaluation. The Behavioral Health Advisory Board recognizes her for her extraordinary effort to reach out and successfully help a person who was threatening to end his life. The Behavioral Health Advisory Board recognizes members of our community who go beyond to help another person suffering a mental health emergency. Corporal Quiros is one of the unsung heroes in Ventura County and deserves the thanks and recognition of us all. Congratulations.
Just want to thank you all, and I appreciate everything that you guys do to support us as law enforcement. And just a huge thanks. As a crisis negotiator, usually I have my team with me, and that day I didn't, but I was extremely blessed because I was with a great group of dispatchers who stepped up and helped me throughout that phone call. That wasn't what I was expecting to happen, but I'm really glad that we made the decision to call him.
Okay, I think your boss, your supervisor, Jim Carroll's gonna want to say a few words.
Good afternoon, my name is Tim Farrell, the sergeant in our dispatch center, and I'm honored to be here today just to speak about someone exceptional. Elise Curios, a corporal here with us. When Elise came to me and told me that she wanted to work in our dispatch center, I knew that we had someone very special. We had someone that was gonna elevate our team and really bring her skills and her abilities to our center. And I'm very grateful for that. Elise is the kind of person that you want in your corner, whether she is taking a call and talking to someone in crisis, whether she's responding in the field to a call. She also serves as a crisis negotiator on our SWAT team, and I have the honor to work alongside her in that capacity. And I think she's just someone that you want in your corner in life in general. It's been a privilege to work with her and just to watch her shine in her capacity and her role. Often when sworn personnel, so she's a corporal, come to our center, it's very often that we have dispatchers that will kind of mentor them and teach them, you know, how to be a call taker, how to slow down, how to show some more empathy. And it's been great to see her in her role, lead by example. She's the kind of person that understands that she's not just there to do a job, but she's there to provide care. She's there to be a human being to the other person on the line. And we really just love having her. I think it's that her ability to connect to people, her ability to show compassion and empathy, especially when people are in their darkest moments and their most desperate time of need, is what really brought this call that we were speaking about today and recognizing her for today to a successful conclusion. You know, it's not always about following policies. In fact, if we were to follow our strict policies and procedures, we likely would have handed this call off to another agency. But I really commend Elise for taking the time to buckle down and speak with this caller, know that she has the connection, the ability to build rapport with that person. And we dedicated a lot of time and energy to this call to bring it to a successful conclusion. I think that we all recognize in this room that when people are in need, they don't just want a police officer, they want a human being, they want someone to connect with. And we're very proud to have her not only in the dispatch center, but at our department to represent us. And so we just thank you for all you've done and congratulations.
Is there anybody else that would like to say anything? Okay,
She's the best.
she's the best, yeah, okay, we got that, thank you.
Just really quick, I wanted to recognize, my wife is actually here, so
She just got
the
here.
best thing about her is she's actually a psychologist, so we brings a lot of
Oh, that's
clients.
awesome.
So huge thanks, to her. She always lets me, you know, run amok and work all the overtime I want, head out in the overtime and call outs and everything, so.
Yeah.
Thank you.
All right. We did have, we did have a comment, from the dispatchers who were there the day with at least one of them anyway. And I'm gonna read it because I just think it's so important to get what was really going on and get the feel for it. And I'll tell you, when I was on the Ventura City Council, as many of you know, I served on, for many long years. No, I'm kidding. One of the best experiences I had was to go into the dispatch center, and I spent 4 hours there, and I have never been so impressed with a group of people. The amount of what they're doing is mind-boggling. This woman I was with was in like 5 calls at the same time. There were so many calls coming in and some they were so fast. So to have Elise there and with that, what there's people are telling us about her is really amazingly. It's helpful and really life-saving in many ways because they're dispatching officers to different locations, and if they don't dispatch enough or they don't go to the right place, it can be a life and death kind of situation. So we want to thank also the dispatchers. That's my personal opinion. So the BPD 911, this is from the dispatch centers. The BPD 911 dispatch center received a call from 988 referencing a suicidal 17-year-old male diagnosed with autism with very limited information during the subject's first including the subject's first name and phone number. Elise offered to reach out to the subject after dispatch was able to locate any research related to the subject and an unsuccessful phone ping. Elise was successful in reaching out to the subject who was standing on the ledge of the Royal Scenic Bridge at the 11823 overpass in Moore Park, ready to jump, which we did not know at the time. For those who do not know, this underpass, and we all know it, is known for suicides as it's one of the highest overpasses in Ventura County. After 3 hours of 3-hour phone call with this subject, Elise took her time building rapport, understanding the subject's wants, needs, and simply trying to connect with him in a moment of pure crisis, all while relaying important information to dispatch. The subject's mother called SVPD, Simi Valley PD, to report him missing and was concerned about his well-being during this incident, not knowing Elise was on the phone with him, doing everything she could to try and save his life. After 2 hours and 48 minutes, Elise gained the trust of the subject, who finally gave her his location of where he was standing on the ledge of the 11823 overpass. So a very dramatic story, but one that I'm sure goes on a lot in your line of work. And we just want to recognize you and everyone who does this kind of work, because it is so important, especially when you have a young person like this who has his whole life ahead of him. So again, congratulations and thank you so much, Elise. Okay, we were gonna have a second recognition, but again, she was able to be here, so we're pushing that to next month. When we also have a CIT recognitions, as Scott mentioned. Okay, we are lucky today to have a presentation, requested by the TAY work group, and so that's essentially what we're going to be addressing. So with us, we have Renee West. Right, I'm sorry, I do know better than that, and Sarah Sanchez.
Okay, hi. So my name is Raina West. I'm the Outpatient Clinical Operations Division Chief here at BCBH. So I'm gonna do the first part on transitioning youth and our basic health services. And then Chief Sarah Sanchez is gonna also present on patient navigation. So I'll start, and I've got about 15 minutes, and then Sarah will jump on. So let's see next slide. So the program I'm going to talk about, there's 2 of them that really focus on transition age youth. So the first one is just our transition age youth clinic. So that's a specific clinic that serves our clients who are 18 to 25 years old. That is operational in the North Oxnard and Comega clinics. Then they serve all of Oxnard, Ventura, and the rest of the East County. The target population is all of our medical eligible transition age youth who meet the criteria for specialty mental health services. And they can stay in the program until they've aged out, till they've reached that 25th year, as long as they still meet criteria for specialty mental health. And right now we have 215 individuals who are enrolled in this specific transition age youth clinic. And then for this age group, we also have a program called Ventura County Power Over Psychosis, and that's the acronym is BHAB. That serves our folks here who are 12 to 25. It's countywide, and the target population are individuals who have had a first episode of psychosis in the last 12 months, and then anyone who's also at a clinically high risk for developing psychosis. And you can stay in the program for up to 4 years. And right now we have 170 clients that are enrolled in that VCPOP program. And then I also just want to point out that here I have Wendy Mosquito. She's the manager, the BH manager over both of these programs, and she helped a lot with creating the slide deck. So our program goals for our TAPE program, it's really to provide tailored interventions to this specific age group so that the youth and young adults can come to treatment alongside other TAPE individuals. So everything's really targeted towards that age group. It involves support systems in treatment if the youth requests it, so anyone that they want to be involved. The idea is to really help lower the rates of hospitalizations and incarcerations, and that's happening. And we also try to increase community participation through successful school enrollment, employment, and volunteer opportunities. And we stabilize symptoms so that the youth and young adults can identify their support systems and be referred to a lower level of care at the conclusion of their treatment. For the Ventura County Power Over Psychosis program, it's the only early intervention program for psychosis treatment here in Ventura County, and it's been happening, this specific program, since 2019. BHAB has passed a fidelity assessment in 2024, and it's an evidence-based program that adheres to the state standards for early psychosis care. And it's certified by EPICAL, and EPICAL is California's statewide network for all TA, and it's now the DHCS's chosen center for excellence for early psychosis treatment standards. So we're working closely with them and meeting fidelity to those measures. VCPOP offers frequent contacts with multiple disciplines on a team for the individual in care along with their support systems. And one of the goals is to reduce the long-term impact of psychosis by helping the individual meaningfully engage in the community through work, school, social connections, and ability to navigate healthcare needs. So the VCPOP program, it's for individuals who have a first episode of psychosis or for individuals who are clinical high risk. So you can stay, if you have a first episode of psychosis, you can stay, it has to have occurred in the past 12 months. For a clinical high risk, there's no set time frame, but the symptoms are still need to be current and present as a primary treatment concern. So there's differentiating symptoms. So if you have for the first episode psychosis, if a person in the moment that they were experiencing psychosis, this was distressing to them, it was dangerous or significantly impairing their ability to function in the way that they were before, that would be a first episode of psychosis. A clinical high risk would be even in the moment of experiencing the psychosis, the individual can recognize that they are having mental health symptoms. So the difference between the first episode psychosis and the clinical high risk psychosis would be that presenting example. So if a youth no longer wants to go to school and their grades are dropping, someone who's had a first episode of psychosis completely believes that their teacher is controlling their thinking. Oh, this is an example, so not everybody would include this, but an example would be the young person completely believes that their teacher is controlling their thinking and is changing their behavior because of that. So that's significant. That's going to be an actual first episode. But a clinical high risk would be that same individual has a suspicion that their teacher can read their mind, but they're still able to go to school and recognize with some support that this may not be true. So those are the two populations that are served at VCPOP, and it's really to work on those clinical high risk individuals to kind of keep them stable so that they might not ever have a first episode psychosis, and then those who have had one in that first 12 months to wrap around and give them all that care and support they need so that they can function. So our different interventions for both VCPOP and transitioning youth, it's individual therapy, group therapy, case management, peer support, nursing support, and then also psychiatric med support. So we're pretty excited that we're going to be converting our transition age youth clinic to a countywide full service partnership for 18 to 25-year-olds. So this program will be adhering to the assertive community treatment, which is otherwise known as ACT model, with a 10-to-1 client ratio, client to staff ratio, and with more frequent contacts and just a even more wraparound services than we're offering now. And we'll be serving around 150 transition age youth in that program. BHAB is also participating in the Learning Healthcare Network, which is an outcome data system used by EPICAL called BHAB. BHAB will provide outcome measured data for individuals in treatment and also show how many consumers in a program meet the program goals. So we're really lucky to be partnering on this project. So they'll be doing a lot of our data collection for us and then making sure that we're adhering to all of those fidelity measures. So that's it for our two transitioning to programs here at BCBH. Does anybody have any questions? I have about 5 minutes. Yes.
Thank you for coming today.
Oh, of course.
And for this information, I have a couple of questions. One is there a brick and mortar Ventura County pop?
Oh, for BHAB?
Yeah, for BC.
They're here in Oxnard. Correct? Yes.
Okay.
Yeah, so they have their whole their team is something here. Okay.
Thank you. And then are they, so do they stay overnight or is it
It's
just?
outpatient.
Okay, outpatient, that's nice. Yeah. And then how many clients are being served right now?
170.
And then, that's great, thank you. And then, when do you imagine that the new act model will be in place?
July 1st of this year is when we're gonna get it all set up. So yeah, July 1st.
Okay, those are all my questions.
Awesome, thank you. No problem.
Andre?
Yeah, thanks, super helpful. Back to the numbers for a bit. How, in broad strokes, how have these numbers changed, maybe over the last 5-7 years? And also, what's the max capacity that the staff can manage?
Yeah, that's a good question. I've only been in this role for about 5 months, so let's see if Wendy knows. Do you know? How has this changed over the last 5 years?
Yeah.
Do you want to come out here and share with me?
Okay, so for BHAB, it's changed pretty drastically. When we took over the contract, there were about 5 individuals that came from our contractor, Telecare. And then in 2020, there were about 10 that were enrolled in the program. So we went from 10 less than 5 years ago to 170. And then for TAE, that has stayed pretty close. We're actually trying to lower the number of clients that are in that program right now so that we can meet the staff ratio to client. So there will be lots of changes.
One more question, if that's okay. Yeah, and is there any association with intensive outpatient programs or partial hospitalization programs into what you do?
I see what you're saying. Well, so the individuals here at BCBH are all doing outpatient, and some of that can be quite intensive, so you meet with them a lot of times, but it's not, we don't contract for transition HU for a partial hospitalization or intensive outpatient. So that, although they do get intensive services here.
Yeah, Michael.
Good afternoon. Thank you for your presentation. I have a couple questions. First one is, how much work are you doing with justice involved youth? Whether they're coming out of, say, probation just down the hall or being discharged from juvenile hall.
So we do partner with juvenile hall, especially if they're not connected to a BCBH clinic already. In my experience, a lot of it just matters if they're already connected, since there are transitional age youth, sometimes in our youth and family clinics, sometimes in our adult clinics, just for various reasons. They're not all centralized in these 2 programs. But if they're not connected to mental health services and they're eligible for specialty mental health care, we partner with the courts all the time. Oftentimes the case managers are picking them up, taking them to court, really kind of as emotional support primarily. It's stressful to be so young and showing up to the courthouse. And then when we can, we get releases of information so we can work together with probation or their public defender. We try you know, again, as long as we can get the consents, we try to bring in anybody who has contact with our individuals in care, no matter who the agency is. Does that answer your question?
Yes, and so so I'm with the public defender's office. And one of my units that I manage is our juvenile delinquency unit. So can I, after this, can I get your contact information in case so that we can collaborate more?
That would be great.
Thank you.
We also do presentations to different agencies, so especially with BHAB, if that's helpful at all, we can coordinate that.
Yes, thank you. And then my other question, having to deal with discharge from the intensive psychiatric hospitals. Is there any coordination with either one of these two programs with discharge for K individuals?
Yes, especially for the ones already enrolled in our program, for both programs. We often try to send our staff, whether it's the clinician or the case manager or even our peer support specialist, if they're in county. So if they're at Vista or Hillmont, we try to visit them so that we can keep that relationship and that they, know we're there for them even when they come out. And then if they have not been connected, we have taken some referrals straight from the psychiatric hospitals when it's, I would say more so when we see pop, when it's very obvious they're having their first episode, and that's what landed them in the psychiatric hospital.
Thank you.
Thank you. So where would you get your clients from then? If it's either from the probation department, we already have heard that Vista Del Mar really isn't up and running now. So other than Hillmont, where would your clients come from?
They would come in the regular way that all of our clients come, so they come through with intake and assessment, and then at that assessment is when they would be referred to transition youth, and then those clinicians in our system who are doing those assessments, if somebody looks like they meet criteria for BHAB, then they would be referred over to this team.
Great. Any other questions? Oh, sorry. Oh, keep forgetting. Sorry, Liz.
Thank you. Just a quick question. You're culling and downsizing current clients that are being served from 170 to accommodate the ACT model. What is your target number of clients you want to serve?
Sorry, so actually, the 170 is BHAB. And
I'm sorry. Right, the other one. I'm sorry, I don't have the other. I can get the number for you, but what is the 215? So what is your target enrollment of clients? And I'm very curious about that, because my follow-up question will be, what's happening to these young adults that are being culled from this this soon-to-be FSP ACT model? Where are they going?
So the soon-to-be FSP would be about 150 clients, and we can expand that if needed. But the rest of the transition youth will be seen in the adult or youth and family clinics, where they're being referred from, and they're already in those clinics now. So some of them are already being seen in those clinics, and so they just continue there.
So then the determining factors obviously are going to be specific to the individual and their recovery journey. But what are some of the criteria that you're using? Obviously, they're not in a crisis. Obviously, they're not acute. But is it going to be a time, like a length of time? They can only stay for a certain amount of time before they get, referred into the clinic or transitioned out of the ACT model? What's the criteria that's being used?
It's the same for all of our FSPs. So the FSP level of care, that ACT level of care, is really for our highest acuity individuals who are in our entire mental health system. So it's the same for this TAY, for the TAY system. So if there's a client who needs more services, who is more vulnerable, more high acuity, they're the ones that are going to be in our FSPs. And then anyone that's able to attend clinic appointments, to be successful in a clinic atmosphere, they would stay in those clinics.
Okay, so then there's always a possibility that you're trying to get down to 150, but depending upon acuity rates, you may not be able to accommodate that, correct?
Exactly, yeah, and so we're gonna meet clients where they need to be met. We're just saying that that's kind of the general idea, because with ACT, you can have, it's a 10-to-1 ratio, so you can
Right.
also have a ACT, which is a 5-to-1. So we were looking at like one full ACT and then another half ACT, but of course, if we need 200, then that's what we'll do.
Thank you.
You're welcome.
Any other questions, comments? Thank you, Raina, very much, both of you, for that presentation. That was really helpful, I think, especially for the complete work group.
Thank you so much, and thank you, Wendy. Good afternoon, everyone. Thank you again for allowing me to come here and talk today, this afternoon, about our patient navigator. So we can go. I was gonna ask if you can. Thank you. So this new position, our patient navigator, is under our critical care navigation services division. So our goal with the patient navigator is to assist members of the public to navigate county behavioral health and other care services to effectively access necessary treatments. So the goal really is supporting the individuals that come into our system or are calling in for services and needing that roadmap to be able to access and link them to the appropriate support. Sorry. With that in mind, we're ensuring that the patient navigator is truly present to listen to the needs and accessing care and their loved ones to support and advocate for their needs. So the goal is this position is one position. So we want to ensure that we're maximizing the resources of the patient navigator. And in the now we're building the infrastructure to be able to support the needs. So we're looking at how best we can support the individuals accessing care, individuals already in our system, support their loved ones as they're navigating, whether it's our behavioral health system, whether it's other systems of care. We want to ensure that we're supporting them and providing that roadmap as they're navigating whether services or now there's another complex need that they're needing that support. And another crucial element as well is to provide the education to the community and the organizations about understanding what our services are, ensuring that we're reducing the stigma about behavioral health and ensuring that we have that opportunity to engage the community about what behavioral health services are. Another crucial element as well is building those relationships with our community agencies or organizations. So ensuring that, again, we're collaborating with other partners, with other patient navigators within our system to be sure that they're as well aware of who to contact if they're needing to be able to access our resources. So as our direct service, what we're doing in the now is when if an individual is calling to access services and that person has private insurance or they're not our level of care and they're needing support to navigate or contact their resources, we're referring that call, that individual to our patient navigator to be able to support that individual. So what we don't want to do is end a call or an individual reaches our clinic needing access, but they're needing to access a different provider or their private insurance. We as well are linking individual to Medi-Cal. So if the individual coming into care is needing Medi-Cal services or other resources within the community, they as well are providing that, patient navigators providing that support. And then most recently, as we're getting acquainted, we're connecting with the patient navigators within ambulatory care, within the other systems of care to ensure that as we're aware of our resources, we become familiarized with the resources and how to access those resources. And we have our patient navigator here, which is Norma Aguilar. She is, although new to the position, she actually was recently recognized at the Board of Supervisors for 30 years of service to our agency. So she not only has been with behavioral health, but she as well has been with public health, healthcare agency and then came back to behavioral health because she has a heart and dedication to work with our community. She as well shared about her own lived experience as a loved one navigating the resources to be able to access care. So she has a passion and dedication for our community. One last item is we're working on developing workshops or presentations that we can provide for individuals and families. So as they're again navigating our system, they're able to connect through this workshops that are gonna become available. We're trying to do a hybrid model where they're able to either come in or be able to connect via Zoom to be able to know about just the different resources and knowing that they're not alone in accessing care. Thank you.
Thank you. Great presentation. Any questions? Welcome to the patient navigator.
I have a question.
Andrew?
Sorry, a couple quick questions. This sounds like a dumb question, but how many patient navigators are there?
It's an office of one, so that's
Okay.
where, yes, so as we're building out the infrastructure, we're looking at, so the patient navigator is a crucial piece, but we also have outreach teams. So if there's an individual needing to link to other resources, there's also our outreach teams and our clinical team that can support with that. But our patient navigator is supporting more on the higher level of those complex cases or situations that need that extra layer of support.
And how was the caseload?
The caseload in the now, it's not necessarily, she'll carry a caseload, but be a point of contact to be like more of a roadmap per se. I see it like a navigation system where it's providing that roadmap to the different resources, either within our department or other agencies or other resources in the community. So definitely it's more to come as we build out and we see what the need is within our department and our community. I see this as Pam.
Any other comments or questions from the board? I see that, but I always take board first. So anything else? Yeah.
Yeah, so what's happening now and where did you guys see that this was the need? Like, what was the gap that's happening right now with the calls? Is it that you're just your team's having to take more time to?
No, not necessarily. Thank you. That's a very good question. I think it's more of being able to support an individual that's calling, that's not necessarily our level of care or have their private insurance. We want insurance not to let them know, hey, contact your private insurance. We want to be able to support because there are individuals that can and will do that, or others that are having difficulty navigating the system. So we want to ensure that we have that availability for individuals. Yeah.
And I'll just add on that, this position's been in the works for the last 3 years. I think I went to the board in 22 to get it. But it really has been recently in the last year or so, collaboration between myself and Dr. Cho when she was the CEO of the AM Care system, really trying to figure out how do we get people in the appropriate system, which as you heard, it's going to be critical as we move forward post Prop 1, where systems are going to have to be responsible for their members and their lives, and really helping people jump back in between maybe a mild to moderate versus a commercial insurance versus, specialty behavioral health, and having a single staff who can work within all of those systems and really know what's there on the other side to really link our community members. So
thank you, Dr. Henry. I think as well as being a resource to our clinical staff and to our direct care staff to be able to know the different resources. Yeah, so.
Yeah, and this is a position that this board was very active in supporting and really wanting and pushing for. So some of you who have been on the board a little bit longer probably remember some of those discussions that we had, but we're happy to see somebody's here and fulfilling the role. That's great. Okay, back to Liz.
Thank you. I have just a couple of comments I wanted to make. For historical context, the board had asked for an ombudsman as a position to work on behalf of clients and families and to advocate during grievance processes and on behalf of individuals trying to get quicker access or troubleshooting problems. And because of some miscommunication, this position ended up becoming this patient navigator that was approved by the Board of Supervisors, and we understand that that was what happened. So one question I have, because it was imparted to me in numerous conversations that this particular role would potentially play some kind of advocate role if in fact that came before them. Is that still the case, or are they just primarily linking folks to services and helping troubleshoot insurance questions and things like that?
That's a good question. I think it's dependent upon what the need of the individual is and their loved ones. We want to be able to best support what the need is. It's not necessarily just linking somebody, but being able to listen to what their need is and be able to either, if it's advocating by linking them to that appropriate individual entity or provider, or if it's being able to support them with the resources or being able to voice what their need is.
Okay, then the final thing I'd like to say, which I think is very important, is in the behavioral health world, we don't use the term patient. So I would strongly advocate on behalf of consumers and clients of the department that we rename this position either health navigator or client navigator, but patient is a medical model term, and we want to use recovery language. We employ a recovery model at the department, and I think this is kind of a glaring oversight. So I would ask you to consider that and see if that can be changed, because I think language is important in my world, in this world, and we would like to be referred to as clients. And if you're not comfortable doing that because of job classifications, then perhaps you could use the encompassing title that's used often as health navigator. Thank you.
Any other questions or comments? Well, thank you very much for coming, both of you, and for your reports. Okay, moving along to board comments and announcements. Any board member have anything you want to comment on or announce? I'm not seeing any. Right, okay. We'll move into old business, the data notebook, Diane.
Yes, thank you. The data number was turned in before the final deadline. It is something that you have to do directly into the system and be new with it. I did not get a print out of it first. I was really lucky. The folks that came up when I was absent last month and the month before gave a lot of the specific data that the data notebook was asking for on homelessness numbers, what we counted when we counted it, how we counted it, and what services were available. So I was pretty comfortable with the numbers that I put in, but I am gonna see if I can get a copy back so that everyone could see it first. But it did have to go in, and it's not like I could get it to everyone and wait for comments, it just had to go in.
Do you have any highlights?
I guess I do have some highlights. I mean, it was primarily, it was very different this year. As they said, there were some narrative parts that I had to put in about what we were doing, which I actually thought was good, because instead of just asking yes, no, do you do this, yes or no, we could explain when we started it, why we started it. And Sarah was very helpful, and Karen was very helpful from the department with those parts of it so that it was accurate. And again, the handout that we got 2 BHABs ago on the homelessness programs that we have were real helpful on the place on Valentine Road. And then some of it was just, we couldn't answer. They wanted to know kind of questions like, how many did we think were going to be homeless within 2 weeks? And I'm like, I don't think anybody really knows that. And then there were a couple regarding leaving the prison system that I couldn't get an answer to. I could get leaving the jail system, but not the prison system. And so I think they asked some questions that were just a little out of our lane, but for the most part, I think that our county had good answers that they were looking for. And I think that we will see how it measures up when they show how all the other counties do their data.
Am I correct in thinking that eventually is posted on the website somewhere? Not our website, but the CalB. Do you know, Michael?
It's a planning council that does a data notebook and posts it. Cal BHBA California Association of Local Behavioral Health Boards and Commissions, I don't believe posts this, but they collaborate a lot in their efforts, but this is the planning council, which is a different entity, and I don't know what the composition is of the planning council, but Dr. Dennery may know more. Okay, wasn't trying to put you on the spot, but
They definitely said it was a new way they were doing it this year, so I was like, yay. I had no role model to follow, but like I said, I think I got good and accurate information put in the system.
Yeah, I just saw Jackie nodding her head, so I think what Michael said is correct. Yeah.
and then the other thing is, you should be able to, whoever your contact was with the planning council when you submitted it. They should be able to get you a PDF copy of the report.
Okay.
Can I just, yeah, so, once that happens, if we could give it to Jackie and have copies made or sent out, maybe it's not electronically, that'd be great. Thank you.
I can tell, the other, if I can't get that, I can draw one and put all my answers on it before I put it in, so. I'm gonna share that, but I was hoping for something a little more professional.
Okay, thank you. And thank you, Diane, for doing that. Taking it on, it's a big job, so thank you. Okay, executive committee membership, we're still looking for possibly another executive committee member, so again, if you're interested, let me know. Okay, we're now moving to new business, and on this, we have membership discussion and survey. And I will say, while you're here, it would be awesome if you could do this, but you, at your place, there's a advisory board membership survey just from this department. You may, be anonymous if you want, that's fine, you can fill out your name if you want, that's great too. But we do need to really look at our membership, and as you know, there are very specific requirements that we have to fulfill. You know, we have to have a veteran member, which thank goodness we now have, thank you very much. We have to have a certain number of consumers, a certain number of family members, someone 25 or under, and someone from the education world, so. And we do thank you, we have a public service person too, we have a member of the sheriff's office, so that's great. So we are going to be looking at, because as you know, we've lost members due to the fact that there was this WIC requirement, which Marty, our county council is going to discuss in just a few minutes. But we need to know, we haven't done one of these surveys for a while, I think, and so in fulfilling our mandates, we kind of need to know the makeup that we have on our membership and what we're gonna be looking for, and then working with the supervisors, working with our supervisor, Lavere, in terms of him working with the other supervisors and letting them know what it is we need and what we're looking for, so that we get a more robust, I think, board. I love this board, I think we're all very involved. And it's sad when we have to lose members because of this other requirement, but that's happening, and it will happen a little bit more, I think, and so we're gonna be down quite a few members, we're gonna be quite low actually, and you can kind of see that because Jackie also prepared a roster, it's a draft roster of who we have currently as members, and as you look at that, you'll see how low we are and how many vacancies we have and which districts they're in. So I'm gonna ask Marty if she's can give us a little summary again of the WIC and how the legal department of the county is interpreting that.
Thank you, Chair. So we went through this, for those of you who were here last month, we went through this in some detail. I think the important thing to remember is that this is it's a conflict of interest provision drafted by the legislature. And they're trying to do two different things, I think, of as I read these two different paragraphs. And for those of you who wanna go look along this, it's back in the packet again, because it was in the minutes. It was attached to the minutes from the last meeting, so you've got the thing that says BHB, WIC, page 3 up at the top. two columns of text. And it's right in front of this summary of contracts, January 2025. So the first provision is, it is a list of people who cannot be on the board. A member of the board, or the member's spouse can't have certain, activity or can't be involved in certain activities. They can't be a full-time or part-time county employee of county mental health and substance abuse disorder service. So anybody who works for VCBH or their spouse works for VCBH, full-time or part-time. And this provision excludes them. An employee of the State Department of Healthcare Services, which since that's the agency that regulates VCBH, kind of see why they might be elected out. An employee of or a paid member of the governing body of a mental health contract agency. So I think there has been over the past a number of people who work with, work with the county, work for county agencies that have contracts with the county. And what this is saying is under section 1, if you're an employee of one of those agencies or you're a paid member of the governing body, you are excluded by this first paragraph. Then the second paragraph is an exception. So to the first, to the prohibition, and the second, and the exception, I think is, sort of the purpose of it seems pretty obvious to me. It's for people who are consumers of behavioral health services. And they have the employment that would have restricted them according to the first paragraph. And that if they do have that restriction, if their position fits a definition that's in this paragraph, and they are consumer mental health services or behavioral health services, then this exception brings them back, if you will. So the first paragraph excludes them, the second one would bring them back. So what kind of people would those be? It would be not people who hold a position in which the consumer has interest, influence, or authority over financial or contractual matters concerning the employer. So if people have a certain level of responsibility in their job, even if they are a behavioral health consumer, that they don't qualify for the exception. So given that explanation, facts, everybody's got their factual situations. I've talked to some of you offline and always happy to do that. Supervisor Olivier, I think you had a question or two, or right? Wanted to make sure we had this, we had part of this discussion last month.
Thank you, Ms. Smith. So I think my general question was, there's several members of the body who I think have their own questions. Do I qualify for this? Do I have to resign? Can I stay? And I don't want to ask for them, but hoping that if there's any potential conflicts, so they can meet with you and get clarity.
I'm happy to meet with anybody.
I need, as the chair mentioned, we need to help people. It's a really effective body. If there's ways that we can keep them, that'd be great. So, as you said, every situation is different. So I think you need to direct counsel from.
Sure, rather than have it in the middle of the speak. Yeah, that's fine. Absolutely.
So, this probably does raise again some questions. Some of you individually can either speak with Marty if you're not sure about your, where you are, or your supervisor's office. But if there are people who also have this general question, not their personal situation, but a more general question about what does this really mean in terms of this or that, this might be the time to also bring that up.
Just a couple general questions. If you're a non-paid board member of an organization that gets money from BCBH, can you be on this body?
Yes, because this specifically says a paid member of the governing body.
Okay.
So if you are a non-paid member of the governing body, you're a volunteer in that organization too. Then you should become volunteer here.
Okay, so the dipping down one, if you are a not regular, but sometimes contractor to an organization that gets money from behavioral health.
So I think we have to talk about what your contract will involve.
Okay, well, let's take mine. I have my own marketing agency and we might do marketing for Jake's place for a little while for a specific thing and then it doesn't go on forever.
Right.
Am I conflicted or not?
So I don't, so if you're not a employee of Nate's Place. And you don't, in your contracted role, because people can be contracted for spot, like, and their manager is for.
Right, it doesn't have anything to do with the money that yeah.
They hire you to do some work and you satisfy them or you don't satisfy them. Right. So then I would say that you are not.
Okay, great. That was what I was told when I joined. I just wanted to reiterate it, well, I did this time when we were going through it. So you agree it helps anybody else? There you go.
Any other, Janice?
Okay, so, and it does specifically say Ventura County Behavioral Health, right? So that doesn't include.
Yes, it's county mental health and substance abuse disorders or.
Okay, that's good. And then, I wanted to mention on everyone's desk today, Jackie, if you don't mind. Jackie left the survey for each of us. And I think it would be prudent, if you don't mind, if we could all fill it out, fold it and give it to Jackie today, so we don't have to wait. Because our supervisors need to know, how many, where we're lacking and what our situation is, so it should be on everyone's desk in the very bottom of your papers. And then, is that okay, Cheryl? Because I just thought since we're here, we might as well do it now. I mean, we only have 2 members missing, I think.
Yeah, that was kind of the intention, I think, yeah. So again, are there any other questions though first before you do fill this out? And if you, again, have a personal situation and you don't want to fill it out yet, or you want to make a note on it and talk to either Marty or your supervisor's office, that's fine. That's fine, just let us know. That's where you are right now. Again, you can be anonymous. On this, we just need to kind of know the numbers and where everybody fits in. So, that's really what we're mostly interested in. Are there any other general questions or comments about this issue? Oh, I'm sorry, Sylvia.
Yeah, even with the other on the way, because it keeps changing as far as what consumer is. Is it just a consumer of mental health or a CBH consumer?
No, it's just a consumer of mental health. No, it doesn't, right, yeah, it's
correct.
Yeah, it's just a consumer or substance abuse, issues also. Okay, any other questions or concerns about this, or when it's not clear? Okay, great. All right, so if you can't fill it out today, great. Fold it, give it back to Jackie. If you can for some reason, that's fine too. But just know we need it, because we can't give this information to the supervisors until we have this, these numbers essentially to let them know. Okay. Thank you for doing that. Presentation requests. We have a couple that we have been requested for upcoming months. Anybody else? Just let us know if we have something, and if the work groups have something that's important, because we did have the TAE request today and that worked out really well, so. Okay, and recognition awards, we have one, as I said, coming up. That CJ's contacting the person, but she's been unable to be here, but hopefully next month. CIT will be next month. That's a lot of recognition for our CIT partners. Anything else for recognition? Again, just let us know. Contracts, I don't think there were any. These are support. Okay. I don't think there were any contracts, really. I don't think so. Okay. And any other public comments? Okay.
I just wanted to thank Jackie for doing this calendar for us, so we can all put it in our phones. It's great to know what holidays and what days the executive meetings are and everything. Thank you, Jackie, for that.
Yeah, thank you for that. And if you didn't get a calendar, they're on the back. If for any reason you didn't get one, they're on the back table, so it is helpful to have. Thanks, Jamie. Okay, well, I think we're done with today's business, unless anybody else has anything. And thank you all for coming and being here. Appreciate it. Meeting's adjourned. Sorry.